Welcome to Perspectives with Pinnacle, exploring the evolving world of healthcare. Let's navigate complexities and unlock new perspectives together.
In rural America, access isn't just about insurance. It's about distance, workforce, and whether the local hospital can stay open and staffed. In 2025, Congress created the Rural Health Transformation Program, a $50 billion, 5-year initiative to aid states in prevention, workforce pipelines, stronger regional partnerships, innovative payment models, and technology like telehealth and cybersecurity. But the design comes with some real constraints. States are judged on implementation progress. Most dollars are meant for transformation rather than day-to-day operations, and big changes to approved plans can create risk. Today, we've brought together some leaders from some of the most impactful rural health networks in the country to talk about how this transformation actually is happening on the ground. And I'm joined by network directors from Illinois, Colorado, Montana, Washington, and the national level through the National Cooperative of Health Networks. Because networks are often the infrastructure that turns policy into execution, creating shared services, shared learning, shared data, and shared strategy. We're going to discuss what rural communities will actually experience over the next year. What's working, what's hard, what must be built for sustainability beyond 5 years, and what other states can learn from what's happening right now. So let's dive in. Thank you all for joining me today. I'm super excited for the conversation. I know we've had 2 full days at the ICAHN conference this year in Dallas to talk about all things RHTP and where the future of rural healthcare will go. I'd love it if maybe you guys could introduce yourself to the audience, name, your network, the state that you're from, and a little background on the composition of your organizations before we start diving into the questions. And Tracy, I'll start with you.
Sure. I'm Tracy Warner. I'm the Executive Director of the Illinois Critical Access Hospital Network. We represent 60 rural hospitals across the state of Illinois, 56 critical access hospitals, and a few PPS hospitals, small rural hospitals, who see the value in the focus exclusively on rural issues as it relates to rural healthcare.
My name is Ward Van Wicken. I'm the Vice President of Strategy for the Montana Health Network, which is the eastern side of the state of Montana. We are an organization of 18 facilities. We have 1 PPS hospital, 1 long-term care facility, and the rest are critical access hospitals.
Great to be here, John. I'm Angelina Salazar. I'm the CEO of Western Healthcare Alliance. We are based in Grand Junction, Colorado. Our hospitals' healthcare organizations are located mostly in Colorado, but we also have a member in Moab, Utah, and then 3 critical access hospitals that formed a system in the Thumb region of Michigan. Our membership, those 33, consists mostly of critical access hospitals. We have 7 PPS hospitals. We have 4 behavioral health organizations and a hospice and palliative care organization.
Good morning. Elia Prostowski, Executive Director of the Rural Collaborative in Washington State. We have 31 rural independent public hospitals in our membership. Almost all are critical access. We have 1 rural emergency hospital in our network and 3 PPS hospitals.
Good morning. Thanks, John, for having us. So I really appreciate this opportunity to kind of unite and raise the voice of the concerns we have addressed in front of us. So I'm Linda Weiss. I'm the Executive Director of the National Cooperative Health Networks. We are a professional membership association. We currently have 32 network members, which represent over 1,800 organizations across the country.
Again, really excited for the conversation. And I thought we would just aim the first question right at the heart. So from each of your vantage points, what's the single biggest threat to the sustainability of rural healthcare today?
Single biggest threat.
Narrowing it down to one, right?
Yeah,
Touche.
Really narrow it down to one because I would say there are so many things that are interrelated. You obviously need workforce, but you need to have adequate payment to have wages that will attract and retain individuals. You need payments for technology or adequate payment to make sure that you have the latest technology. So it is also a matter of declining populations in rural areas. So many times you have smaller volumes that you're treating. So it really is, from my perspective, at least, a dynamic that everything is kind of one issue in terms of, yes, there are challenges left and right. And then it's just, of course, a matter of how we can deal with them.
Yeah. And I like how you said that, John. What's the one challenge issue today? Because that's going to change tomorrow. And as it was different than yesterday, right? So that's That's the dynamic that we're in today. Anybody around this table or anybody that might be listening, people know me, I'm going to go right to workforce. I'm a people person, right? So the only thing, I mean, you can have all the fancy technology, the finances, all that stuff, but if you don't have the quality, qualified people to actually do the work, you're not going to get it done. So for me, the biggest challenge is workforce. And that's what I hear when I go around to our members and other CEOs and hospitals around our state. That's their number one thing that they want to talk about.
I think in Colorado, and I really appreciate what you just said, Tracy, because I think it is just this interconnected elements that come from all these different directions. So I really appreciate that. For Colorado, Michigan, Utah, what we hear over and over again is just the reimbursement issues they're having. Payer denials, not getting reimbursed for the care they're providing, which makes it increasingly more difficult to be able to provide the care. So we're seeing hospitals having to make decisions to cut services like OB. So we're finding that's the first time that's happened, especially in Colorado in many, many years.
I would say it used to be workforce in Washington State. Washington State has been pretty fortunate in being able to overcome a lot of those limitations. The single biggest threat to rural healthcare in the state of Washington is getting paid for the work that the rural hospitals provide. And already they were all operating on thin margins on the bleeding edge. And now there are additional threats to what little revenue they have coming in, first through HR1 and secondarily through enhanced behavior by insurance companies to deny payment. So there's a double threat there. And if those two things cannot be addressed in some way, I think we'll see a lot more closures.
From the national perspective, our members across the country, if we had all of them here around a bigger table, they would all say some version of what these four folks have said. You know, maybe workforce is a little more of an issue in this state than that state, but overall, what they just spoke to is what any of our members would talk about that they're dealing with across the country.
Well, it's interesting because RHCP is being positioned as a once-in-a-generation investment. So what makes this moment different from prior rural health initiatives that we've seen? And that's really for any of you.
I'll take the first stab. It seems like an obvious answer, but I'm going to say it anyway, is this is what we have, right? So that's what makes it different. This is where we are. Whatever happened in the past is in the past. So where we are right now. I think the other thing that seems different to me is it is nationwide. It's not region. It's not these 10 states. So I think those two things, this the here and now, and it's the national agenda, if you will, as opposed to region or state specific. And then there are identified pillars that I'm sure we'll get to. So I think that makes it a little different than what we've seen in the past.
Add to that just a little bit, or maybe add some color.
You always add color.
A little different color.
That's why we invited you.
I'm trying to keep my hands down here and not talk with my hands. But so I think one of the things that I'm sitting here thinking about as you made your comment is, to me, it's the first time we've gotten money ahead of time of the work. Before you had to do the work and then get the money and the reimbursement that way. Now, is the money flowing yet? No, but they're allocating the money. Here's your work. Now go do it. It seems like it's in reverse of what I've been used to in healthcare over all the years, but seems to be different.
Linda, you brought up the national view, and I would say that the focus is there. I think we know that there was some momentum in Washington during the negotiations to pass the budget reconciliation bill. And the whole reason that this funding came about was some very active conversations from representatives from states that would have, a huge impact on some of the other provisions that were in the reconciliation bill. So it's frustrating that on one hand, we had to have money put in to somewhat offset what's being taken out. But that's concession that was made. So at least having that elevated enough to a national level that it became part of the budget reconciliation in HR1. But the other thing that I would say that makes it different is, besides that focus, is the infrastructure. There is a new Office of Rural Health at CMS. So it's the first time at a federal level that the Agency for Medicare and Medicaid are paying attention,
Right.
to rural by putting this structure in place. But with that structure comes a lot of overhead and cost. So you think 50 billion sounds like a lot of money, but there's a lot of states and a lot of people and a lot of consultants that are doing a lot of work, and that translates to hours and dollars that would not be going, directly to rural providers who are already, like has been mentioned, working on very thin margins and struggling with reimbursement issues and how to do the things that we've already discussed as far as workforce technology.
Yeah, and I definitely want to circle back to that a little later when we get deeper into the conversation, because honestly, that's one of my concerns, right? Is how much of these dollars are going to go to the actual communities and hospitals they're designed to serve versus the bureaucracy, the administration, the grants, all the overhead that it kind of comes through that trickle down effect. But when you talked about the national, kind of the regional versus state and how this has been designed, it was really interesting to have Brock here from NRHA, the Federal Office of Health Policy, some really good presentations at the conference this week. I really would love to hear from your perspective where the gap is in terms of a national and state level and how this is being rolled out from a policy perspective. But also, in your opinion, how do we close that gap to ensure that we're actually creating sustainability for the members that you serve and those patients in those communities? What does that big difference look like for you? Or if we were to redesign it, how would we fill those gaps in a more practical way?
That's a big question, John.
That is a
How
big
much
loaded
time do we
question.
have?
I told you we were going to start aiming right for the heart. We're getting into it.
Let's go. Jump in both feet.
I have to say, and so I was just thinking of one of our presenters yesterday who talked about the abundance mindset. But before I go there, let me go from the lack mindset. I think in what I hear over and over again is that the funding that we're supposed to get from RHTP feels like a consolation prize because of the cuts that are coming, the tsunami that's coming that I know our hospitals are preparing for is daunting, to say the least. And it's also creating one of my board members, as a matter of fact, is calling this the Hunger Games because it's like everybody like, and there's a lot of busyness around money that's not going to ultimately fit the need.
Yeah.
So let me get to my abundance mindset. What I'm seeing amongst our members is more collaboration like I've never seen before. So like Elia's network, the majority of our members are also independent. And so they're collaborating in new ways. They're meeting together regionally and talking more about how do we fix this on a local level versus relying on our federal and even our state government for answers.
And I would say to kind of that part of the disconnect to me, and I think many of our peers in Montana, is they really don't get rural, or we say frontier healthcare. I think this now has raised the level of the conversation and the interest and the focus on rural, and having venues like this, John, that you've provided to us here for NCHN and our membership to then tell the story. I think it's important not only in our states, but nationally and everywhere because they don't really get it. I mean, I get home today, I fly to Billings, I got to drive 3 hours to get home. And people from a lot of places, even in my state that they live there, they don't get that. Mm-hmm. So I think we just got to continue to tell the story to everybody and anybody that'll listen.
I think going back to your question, John, about the disconnect. I read the whole NOFO. It was 120 pages.
You did?
I did.
She did in a half an hour.
I did, and I did not use AI to summarize. I actually read it page by page.
Wow.
There are some things that are bullseyes. There are some things that are so tone deaf that are extremely frustrating. And I will give you one example. There was a lot in there about remote wearable technology. And I don't know about your states, but the idea of some of my rural communities having remote things on their bodies or in their house where they don't even have broadband internet, they may still have a landline, they probably don't have access to a vehicle. It's just outrageous and just tone deaf is the best way, I think, to describe it. The other disconnect that's sizable that the National Rural Health Association is working on is the limitations on spend on technology. And spend on infrastructure, because what's happening is these hospitals are there's nobody more resourceful than a rural community. They are the most scrappy, resourceful Americans that I know. And they are working in buildings that are 50, 60 years old that have, sump pumps and leaking, and the roof's leaking. The building's not strong enough to even hold a CT scanner. So they have to reinforce the floors to get the CT scanner in there. And this NOFO misses the mark on those critical investments that allow these hospitals to stay open. And that to me is a huge lost opportunity, because you could do all the technology you want and hire all the people, but at the end of the day, healthcare is a personal transaction, and people go to see their doctor and they need to know. I mean, I'm not saying there needs to be a waterfall in the entry as there are in some hospitals in this country, but it needs to be clean and tidy and safe and respectful of the care that they're getting. And in that, I think the NOFO missed the mark. And I don't know if there's a way to get around that, but that was a disappointment.
You're exactly right. Exactly right. I couldn't agree more with that. And I would take that a step further and saying this isn't just an assault on rural healthcare. It's an assault on rural life. Because we talk a lot in Illinois about the economic impact of hospitals in a community where they are often largest employer, and they have a multiplier in the community as far as creating jobs in retail and restaurants and the local gas stations, childcare, schooling. You need all of that to bring healthcare, but also to keep healthcare there. And if the hospital goes, so goes the community. And that disconnect, I think, was missing at the negotiating table when it was like, okay, if we take this much from Medicaid, which impacts disproportionately rural population, but we'll put some of this back in. But oh, by the way, you can spend it on technology. It's the new shiny things. And some of the conversations I've had is, how do I roll out as a CEO new things when my staff may not get a cost of living increase for second, third, whatever year in a row that you want to name. So it is that disconnect. I like the way you said that, because it really is. It's like, okay, let's do something new and great over here that we can do. Telemedicine's a buzzword. The congressmen are like, great, we'll do telemedicine. Same situation, the border of Illinois and Kentucky. They don't have broadband for patients to do those rural wearables or even have a telemedicine visit. Right. So huge disconnect.
And I kind of want to dive in there just a little deeper, because I also got the impression this was a bit of a top-down approach. And so, in the Army, we used to call it the privates mentality, right? You've got to get down on the front lines where the work is being done. And usually they have the most innovative solutions because they've had to figure it out. And I feel like that's the same for rural healthcare. And I'm not sure that those stories and those messages were being conveyed up the ladder as these decisions were being made. And I like what you said about tone deaf. And so normally I don't bring a lot of notes to these conversations, but I wanted to make sure I didn't miss anything. And so for the audience, I want to bring you up to speed on some of the caps. So what Elia's talking about, from a capital expenditure, that's less than 20% of whatever you were awarded. For your provider payments, it was less than 15%. For EMR, less than 5% if you're high-tech certified. From a tech catalyst perspective, less than 10%. And then from an administrative perspective, at your level, less than 10%. So the way it's structured puts constraints on how you can leverage these dollars. And so I've been in these communities. I think we've talked about it. I spent the first 10 years of my career traveling across the country with critical access hospitals and federally qualified health centers. And I have not only seen the impact they make in those communities and how they drive the community as the employer and as the commerce source, but I've also seen the converse of what happens when that hospital closes. When the hospital closes, it's one of the largest drivers of economic input in the community, but it also drives the education. It drives the commerce. When that hospital goes, so does all of the industry, so does the commerce, so do the shops. And I have seen those shuttered communities, and I've seen what that does. So this isn't just about the healthcare component. This is about the way of life and what you mentioned in terms of the attack on rural life. So my question for you would be, from your perspective, how do we ensure that this doesn't just fund activity given those constraints, and that we can actually create, to some degree, structural transformation on the care delivery and the sustainability of these organizations? And I know that's a little bit of a loaded question, but I think with those constraints, how do you operate with those constraints?
It is a loaded question. And so to give these network leaders a chance to kind of think about how they're going to answer this question, I'll jump out there and give just kind of my national thought. One of one of it is, I think, the timelines that are put on things are just ridiculous. And so I think, I don't know how we change that, but when you're talking about making any kind of change, it doesn't happen overnight. So when you're talking about doing something that's quote unquote transformational and say, oh, we'll get this application in the next 65 days or 62 days, whatever happens to be, and then you got to start doing this work by this time, is just unrealistic. So that's number one. And the other thing I think is, I'm not sure, and I think this is the piece that they can speak to within their own states, is I don't know that the money and or the information, well, the money hasn't even come yet, but the money and or the decision making is not necessarily in the right place. So I will admit I'm a little biased, maybe a lot biased, but each of these folks at this table, if they and or their networks were the ones making the decisions for how to utilize this funding to really transform healthcare delivery in their states, it would be much more effective and much more transformational than I think it's going to be, because the people in the know are the people at this table, or in the people that they represent. And I am not seeing largely those people are at the table in the decision-making process, because the boots on the ground, as you said, these are the boots on, they know their communities, they represent all these facilities and organizations in the states and the areas they serve. And some of them are at the table and have been, and others aren't at all. And I think that's a big piece, because and also without the money, they've been doing it for years. They've been forming these networks and doing change and transformation and how care is delivered in their communities to improve the quality and improve access. And that's why these networks have been formed. So that's what they've been doing for a long time before we ever got here. And so why those folks, those networks, these representatives of the table weren't a required part of this doesn't make sense to me.
I feel like that's a mic drop moment.
Yeah, I was just going to be like,
But I don't want to pay for it, so let's not drop it.
I got you, John. It won't cost you.
So I got a couple comments. I'm going to go backwards a little bit, and I'm going to have to ask you to repeat the question because I've already forgot that. Piece that I said earlier. So I want to kind of go back a little bit to that infrastructure piece, and because I mean you're right, we got all these Hilberton facilities that were built way back when, and everybody says, why do you got cranes over your campus, right? And why are you doing all this fancy building? You're right. You don't need a waterfall, but you do need a clean environment, infection control.
Yes.
And it's amazing how in the community that I live in, when I'm a recovering CEO, and when we built that, our census went from less than 1, we're like 0.1 up to about 3. And that was a new building. You know, it's all about the people too, but you have a new building. It's amazing what that can do for your utilization of your services. And then that kind of ties into those statistics that you said there, John. In our state, they're saying you're going to get some of those money for that infrastructure stuff and all that. The big stick is, though, this word in our plan was right sizing.
Yeah.
So we will give you this, but we're going to go back and do an assessment evaluation, and you're going to have to right size your level of care and types of care and utilization. That's got a lot of people in Montana nervous about what that means, because they're all flexing and moving and, expanding and contracting already. And they don't want somebody from the outside to tell them what they should do. That should be a local decision for what's best for their community. So that kind of ties to those pieces a little bit. And then I think later on, you have some questions for me maybe about, how do we as a network and maybe healthcare providers in our state have a voice at that table, how the funds get spent and kind of where it gets to the front door, right, of the facilities. We have what's called the Center of Excellence that was being developed and they're going to be deployed in Montana. And I know we're going to talk about that a little later. I can at least tell you what I know, or I think I know, maybe is a better way to say that, of what's happening in Montana. So,
Yeah.
I forgot the question too.
So how do we not just fund activity, but actual structural transformation?
So let me just start by saying I feel really lucky to be in Washington State. We were named in the application, our network. So we are one of the few. There aren't very many across the country. Very fortunate and grateful. For the collaborative, the Rural Collaborative, my organization, we are focusing our pot of money on things that have an immediate and significant return on investment. and that increase or at least maintain access to care. We are not getting fancy. It is brass tacks. It is shunting blood to the essential organs. It is training existing staff on how best to increase the likelihood and the amounts that they get reimbursed for the work that they do that are based on pre-existing and agreed upon arrangements with health insurance companies. And it's on leveraging technology to be able to see more patients. So things like ambient listening that could help providers see more patients and not spend less time coding and documenting. So that is the focus, at least in the short term. We still don't know the full impacts that will occur with HR1. It's like we could see the storm coming, and we're scared of it, and we're doing everything we can. And I think I'm glad that this is a 5-year program, this RHTP, so we could pivot and shift to meet the needs that are uncovered as the federal legislation rolls out.
So now that I know the question again, I think I might have an answer from my perspective anyway. I think the interesting thing for me, and I think our network and our state, is how will we define that we've been successful and made a change, us, versus how they're going to define that in the plan and the metrics that they have to meet. Because like in our state, in everybody's state, you got a 61-page document, gets down to 25 pages, then it gets down to about 3 slides in a PowerPoint. But when we were looking at that, all that craziness, the state goes, where you really need to look, and where we're trying to drive the changes in the metrics that they've really identified, that they've got to, like in Montana, we got to increase our APP providers by 5% over 5 years. What is that going to mean? I don't know. We're probably going to lose 10 and gain 5, So I think that's the hard part, is how were we going to, in the healthcare boots on the ground, measure our success versus how the state's going to for their plan and how the feds are going to define it. So there might be some disconnects within some of that as well.
We were fortunate in Illinois to also be named as a sub-awardee. So we're administering 3 different pots of money as it relates to workforce, technology, and then disease prevention, disease management. So the conversations that we've been having around those 3 initiatives are about the structure of a program, using data to define the problem or the need in the case of a situation of healthcare workforce growth, or in technology, really more through an assessment to identify rather than being able to demonstrate not only to the state, but to the federal government that there was some needs identification, there was some data that we used in that. But the other part of the conversation is focused on the metrics. And one of the challenges that we've seen so far is that a metric that was applied to a category that makes absolutely no sense. And so at least having that exchange. And I feel like the state is listening to us and trying to understand that they're under some pressure, of course. But then as they turn to the different organizations that they've named as sub-awardees or within state government that they're doing different initiatives with different pots of funding, that the metrics that are there may not always make sense, but we look at what we do in terms of quality or financials already. So in some ways, it's a structure that we might be somewhat familiar with, but I think it really is more that input on what is the meaningful measure. But even before you get to the meaningful measure, going back and saying this isn't just a broad brush to say this community has to do this, or this, like in technology with broadband. It's more the conversation and really the influence that we've had with the state to say we need to define this community by community by community, because different hospitals are at different points in their kind of journey. But the common thing across our members, and I know this is common across the country with rural hospitals and the people that live and work there, is that they see a need and they do what they can to meet it, regardless of whether or not there's a $50 billion grant coming down. They're figuring out what to do. And that is the message I think that really needs to be elevated, not by just our hospital people, but by all rural communities, to correct some of that disconnect that should be there if you have elected officials that are knowledgeable enough about their constituency base. But that's some of the I guess how we're trying to go, to come back to your question, to say really trying to influence and talk about what are we measuring, and is it something that you can see some movement in a short period of time versus over 5 years. Some of these education programs, it'll take somebody 2, 4, 5 years to get through medical school and residency to count as, okay, now I'm a doctor ready to practice.
The only thing I'd add is for Colorado in particular, I mean, we have 3 states, but they all have different, that's what's been so interesting.
Right.
It's just how the states are handling this, and it's so different. For Colorado, I think they're doing the best they can, considering the timeline, Linda, that you brought up. We are, let me back up, looking at all the things that we've already done in Colorado, particularly with our population health company. When we saw the criteria and our members were like, it was their hair on fire, like, what are we going to do? There was a sudden realization, oh, wait a minute. We do all this. We already do this. The challenge is, how do we scale it? So then I flipped it from, all right, is this really, I mean, we don't even know when we'll get the funding, but it doesn't change the fact that we're going to continue to do the work. Heads down, we're doing the work, whether or not we get the funding. And so we had a vision before our HTP to have a statewide clinically integrated network for all of the independent hospitals. That was already in the works. So when we got our HTP and we look at that and we're thinking, there it is. So we were ready when the state said at the 11th hour, we're going to write you in. You have this much time. Please give us all your information. Now we're just got to hurry up and wait. But meanwhile, we're still doing the work. We're ready to go.
And maybe this is looking too far into the future, but I think, you talk about where we're going to get the return on our investment, where we're going to get the wins. And so some of the challenge and the allocation of the dollars, in my opinion, the conversations I'm having around the country are, how do we get the quick wins so that we can show progress and movement, and that way we can continue the investment, and that we're not jeopardizing future dollars. But then also, where can we pull the big levers that are going to give us the most return, that are really going to make impact? And so I don't know if we've looked that far ahead, and if you have thoughts, I'd love to hear them. And if not, that's okay. We can start diving deeper into some of the structural stuff. But from your perspective, maybe after year one, like, what's one change maybe a rural resident should expect to experience or feel? And then even more so, maybe year 2 and beyond, to maintain that political and community power, and to see that is still going to generate additional dollars as you start to refine your plans. Have you guys started working, having those conversations, thoughts or ideas around kind of what that would feel like in your communities?
I'll go first.
Go, Ward. Go. And Ward continues.
There it is.
I should use I'm sorry, I'm going to go off script for a second. I should use an acronym that I just learned about 6 months ago. WAIT. Why am I talking? But I'm going to talk anyways.
We're glad you're talking. Glad.
So first of all, I think in the first year, I don't think we're going to feel anything. I don't think our communities in our small areas and critical access hospitals and wherever are going to feel a whole lot. I mean, in Montana and maybe some other states, I don't know, the timelines are getting so short, they're just shooting out big chunks of money and saying, here's $300,000, here's 5 metrics to choose from, pick 3. And we're going to measure it and see how we do. That's how they're going to try to impact that change now. But kind of to Angelina's point, they're already doing that work. So I think their vision is that they're going to be able to hire people and resources, technology, or whatever, to do more work, to become more efficient and effective. Maybe some technology and stuff, but as we all talk workforce stuff, you can't make them out of dust, right? You got to still find people, and that's still the problem. So further on down the line, I'm cautiously optimistic, to be honest with you. Everybody knows me. I'm optimistic. I added the cautiousness in front of that. But I don't even know if we don't know what we don't know. So I think it's going to be very hard for me to even sit here and guesstimate what that might look like.
But Ward, they're going to be avatars that provide behavioral health, according to Mr. Oz. When can rural community members expect to see a behavioral health avatar for their needs?
In Washington, maybe next month. In Montana, 6 months.
And this is why I love you guys. This is where the real work is being done. Right?
Humor is our coping mechanism.
Absolutely.
I do think one thing we could expect to see, maybe not by the end of 2026, but certainly starting in 2027, is access to specialists, either virtual or shared among our networks. Because what's happening is as HR1 rolls out, people lose their coverage. Already it was hard to find people to take these specialists in the systems on Medicaid. Now they're uninsured. So I do think we're going to get a lot more creativity and access to specialty care. And that is so important for rural communities, so they don't have to drive to see their rheumatologist or dermatologist or, cancer care. I think that, for at least from my 30,000 foot level, looking at what these states are doing, and trying to put myself in a rural community member's shoes, because they're not going to know when you go to a doctor's office that they're using DAX technology to record. Right. They're not going to see that. They're not going to feel the efficiency. Nobody feels that. But they might benefit from some of the other things.
Well, I would add to that, though, Elia, that they may feel that in terms of, I'm a doctor, now I'm looking.
Oh, yeah.
And speaking to you rather than I'm sitting over here
typing.
Or I'm looking things up. So I think that is a real possibility of what they might, come away thinking, oh, something was different. I really felt that I was listened to, and the physician, the provider was present during that conversation. But I'll go back to what you were saying, Angelina. It's being done some places already.
Yeah.
Organizations that have had the vision and the understanding that technology is out there. This would be great for patient care. This would be great for reducing the documentation time and increasing what doctors call pajama time. They have more time. They don't have to chart. So it's a workforce issue, but it's also a patient satisfier, and it's also to some extent an access situation, because I haven't seen any statistics on whether or not a provider can increase the number of patient visits during the day. But I wouldn't be surprised if it doesn't have some sort of impact on more immediate access, so that if I call to make an appointment at my provider's office and they may have been saying, well, you can't get in for 4 days, that, okay, maybe it's 3 or 2 or same day or something like that. That's purely my speculation, but that could be entirely possible, because that type of technology does create some efficiencies in the process that could lead to more availability for care.
I like the efficiency in process. And I think what you just hit on is that even if we still have limited resources and limited time, at least it feels like it's a much more quality visit. I think that's what we've got to get back to. And I mean, not that I'm a fan of paper charts, but I do miss the days where I could actually have a conversation with my physician and we had to spend some time and really talk through things. And I'm hoping at a minimum, we can get back to that. That I think could be a real win for me. So, yeah.
Yeah. And I think as I sit here and think about our conversations, and we're thinking about the dollars and the processes at the federal, state level and facility level and all that, I think something we all got to remember, and I got to try to remember from my nursing roots, is it's about the patient. At the end of the day, we got to do things that make it better for them. Quality, quantity, access. But I also add the word availability. I mean, we have access to providers in Malta, Montana, but they're not there on Saturdays and Sundays. So the availability becomes different. So I think it's good distinction between access and availability.
Sure.
Well, at the end of the 5 years, right? When the money's gone, what does it need to look like for this to be considered a success? That's the softball. I was saving that till about the
softball.
That's a softball.
Thanks for saving us, John.
My simple answer is that something looks significantly different. I think the worst, not the worst, but one of the worst things that could happen is be at the end of that 5 years, whether it's the patient, whether it's the provider, whether it's the folks at these table, are like, this is exactly the same as it was 5 years ago. I think that is like what we don't want to happen. Right.
Exactly.
Yeah.
I'm very concerned that may be the case because of everything that we've talked about with the challenges. The money's not rolling out. The directives may not be meeting specific community hospitals' needs. So I may be directed by my state. There's funding for improving cancer rates, but yet I identified that as my organization and community through a community health needs assessment. And over the last 3, 4, 5 years, we've already been addressing it. So the misguided application of the funds to places that aren't being identified specifically by a community through their data and through their experience and knowledge of their community, that we have been having those conversations with our state to say, you've got to let the hospital, you've got to let the community define the need. And again, whether or not that's in a workforce Some places it's a shortage of lab techs. Some places it's more like a CNA. Some places it is physicians or providers, but that has to be a community. It has to come from the community in that decision. But I do have some reservations that the concerns that even came out early on as well. This money's not going to go directly to hospitals.
Mm-hmm.
We haven't seen all the distributions yet, but you look at some of the limitations there and all the other work that's going into, state agencies are hiring people. CMS has hired more people. So not getting the money to where it needs to go. And then those needs are not based on what the hospital and the community have identified as the most important element that they need to address to transform their community and their community patients and the health of the community that they serve.
For me, I think I look at some of the statistics, and it was really interesting to hear Brock say that we haven't had a rural closure in the last 18 months, which is insane. Now,
That surprised me when he said that.
some of that
actually.
is obviously due to the REH, but
Yes.
from my view, it's the statistic was there's a hospital that closes on average once a month since January 1st of 2010, and that's just the wrong answer to me. When you think about the access to quality healthcare, it should be an inalienable right. Everybody should have access to healthcare. So for me, it's to not see any additional closures, I think would be one big win. And then I think getting a little deeper, some of the things I saw in some of these applications, and Elia, I think maybe you could talk a little bit about this, is not the obstetrics closure. That's one of the things that you purposely wrote in because of the challenges that we have with prenatal, which is one of the tenets of what we're trying to accomplish with RHCP. So for me, those are some of the things that I want to see is how do we create the sustainability? Maybe we don't necessarily, overly transform healthcare in rural communities. I think there's opportunity there, but it's how do we stop the bleeding, and how do we keep these organizations in these communities to be able to provide those services to those members, for me at least. So yeah, I'd be really interested too to maybe pivot slightly and talk a little bit about some state initiatives, if that's okay, because I think there's a little bit of nuance to each of your organizations and what you guys are focused on. So maybe, Angelina, for you, can we talk a little bit about some of the good work that you guys have done and where you are not only with your CIN, but kind of building that statewide alliance with EPHC. And I would love to hear a little bit about the PBA because I was really intrigued by that as well.
A lot of alphabet soup there.
It really was, right?
You might have to. I was saying, do you have a teleprompter?
You might have to articulate it.
To see what all those acronyms are.
Can you break down the jargon and the?
Well, thank you. I'm excited about the work that we're doing in WHA. So under the umbrella, just for your listeners, under the WHA umbrella, we have two companies that are owned by our members. And one of them is our population health company called the Community Care Alliance, and started in 2016. So like I said, this work has been going on for some time, but the vision in the last few years, especially with our partners on the eastern side, the Eastern Plains Healthcare Consortium, was how do we lower the cost of healthcare, keep those decisions local, improve the patient experience, ultimately, improve the provider experience. All of those things, the quadruple aim, it's probably more than that now. How do we do that when we have evidence that what we're doing works? Now, how do we scale it? And so the Eastern Plains Healthcare Consortium and WHA have been having conversations for over a year about what this could look like. And now we're ready to go. So it is really exciting, John. I think, again, like I said earlier, when you ask that question about, what are we going to see in a year? I agree with Ward. I don't think we're going to see a lot different if we're looking at how this is going to impact us from the Medicaid cuts and the RHTP funds. But when I think down the line, whether this was happening or not feels somewhat irrelevant because we're going to, like I said, we're going to keep doing this work. So you all know this as network leaders, but that word innovation, don't you kind of like roll your eyes because it's like a daily thing for us. The independent leaders, the independent CEOs that we all work with are incredibly innovative. And an example, and thank you, John, for bringing up the PBA, it's called CCA-RX. And I want to say 3.5, 4 years ago, of course, PBMs.
What's a PBA, Angelina?
I'm getting there. Let me start with the PBM. The big PBM, so Pharmacy Benefits Manager. They, I know more now about that world than I ever wanted to know.
Spread and rebates.
Yes.
The game is the game.
It's a game. And our CEOs didn't want to play anymore. Like, we don't want to play. This is not working for our patients. It's definitely not working for our hospitals. So decided to create their own PBA. And the difference is transparency. Pharmacy benefits administrators or direct pass-throughs. You're removing all the middlemen. You're removing all the games. And yeah, it's just direct. Our member hospital pharmacists actually control the formulary for their communities. So they meet regularly and talk about, okay, what do our communities need? And they talk about those medications and they talk about cases and they learn from each other. It's collaboration at its best. In fact, Montana Health Network joined our PBA this past year. And so, yeah, we're really proud of that work. And knowing, I think, again, it's just a testament to our rural scrappiness, like you said. But when something's not working, you're like, okay, how do we take care of our patients? How do we take care of our local communities?
Yeah. Well, if there's a takeaway for the audience, it's you need to reach out to Angelina and learn about this because I was so impressed, number one. And then number two, have you had a conversation with Mark Cuban? Because I think there's some real opportunity.
Hold on, let me just text you. Mark, I'm just kidding. So Mark Cuban did endorse our PBA.
That's awesome.
Yeah, so we are endorsed PBA. Have I talked to him personally? No. Hopefully after this podcast.
Well, he's here in Dallas. We'll make sure he gets a copy. Yeah.
This is not a podcast. This is an executive round.
Executive round. That was a big win, knowing that we're doing the right thing. I mean, we knew we were doing the right thing.
Yeah.
But having national recognition like that does feel pretty good.
And I also would imagine an endorsement, regardless of the name, but an endorsement from somebody outside of your circle.
Yes.
Right.
I know. I saw that and I gave her a text high five. I'm like, that is awesome.
That is incredible because it is one of the biggest challenges.
Well, the credit goes to the hospitals. They're the ones that decide to do this.
Yeah. And Elliot, one of the things I really liked about what I saw in yours is the idea of independence through interdependence. And interestingly enough, so I used to run operations for an IPACI in here, and that was our philosophy in talking to our independent docs is the definition of independence is going to look different. It has to be interdependent. And so for the rural collaboratives, how do we build that? What does that look like for you all? And how are you kind of creating that coalition? And maybe a little bit of the nuance you could hit on about being the public hospitals as well and some of the differences between that and the traditional critical access hospital.
Good call. So in Washington State, we have a preponderance of public hospitals. All of my members are public, which provides a lot of unique opportunity, but also some challenges. So in terms of their ability to integrate, they are public and their boards are public, and they have by statute things that they have to do for their community that makes it really hard for them to merge or form anything other than what we have at the collaborative. So the way that the collaborative is structured is really through relationships and trust. There is nothing that forces members to be part of the collaborative. It is a group of the wanting, not the willing, is what I say. And the day you stop wanting, that's okay too. We don't need everybody in for it to be effective. To this date, nobody has withdrawn. We continue to grow every year. However, the collaborative is structured such that when you sign, you're signing a commitment to show up and to lean in. And in terms of participating in joint ventures is probably a trigger word, shared services and programs. What was it yesterday? I mean, it's not manipulation. It's research gathering.
It's influence.
It's influence. And the expectation for our hospitals is if you're looking to change to a new GPO, you look at the one that we have together first. Yeah. And if you could beat it, Godspeed. Yeah. Congratulations. I doubt it. But if you could beat it, we want to know.
Right.
And also, but if you can't beat it, or if it's net neutral, please join together because that raises all boats. And there's a CEO to CEO engagement that it's almost like it's so powerful. I can't even find that. It's not like they twist each other's arms, but I'll give an example. We have a employee retirement plan shared through Multnomah Nationwide. And one of the CEOs called another and said, "Hey, Josh, Josh, why aren't you on the plan?" And he's like, "I don't have time to look at it." He's like, "Well, if you join the plan, my employees' fees go down by 5%. And Josh said, "Well, I didn't realize that, Larry. I will look at it." And they joined. So that, I mean, it's not contractual. It's not manipulative. I don't know. It's like
the 3 Ps.
What is that, Angelina?
What is that?
Positive peer pressure.
Positive
Taking
peer
notes.
pressure.
All right,
Yeah,
it's a new
positive
act.
peer
Yes.
pressure.
I think that's a presentation Angelina's doing at next year's
Yes.
conference.
I used to call it the 2 Ps, pleasantly persistent, but I like yours better.
The idea that you hang together or you hang alone.
Yeah.
And that is very real. I don't know how else to explain it other than if we're going to take that back to RHTP, what we're doing at the collaborative is accelerating work we wanted to do. It's just fast tracking it. There's nothing that I agreed to do that was out of the scope of what we needed to do. And our vision through all of this, going back to one of your earlier questions about what does success look like. From our perspective, success is that rural Washingtonians receive the same or better access, quality, and cost of care that urban Washingtonians receive. We don't want to be less than. We don't want to be the little buddy. We feel like rural Americans deserve the same or better than urban Americans.
I knew we were going to circle back, so I really want to talk a little bit because one of the things that excited me was the Rural Center of Excellence. And so I'd love to hear a little bit about that, but also what that, I would say restructuring, right sizing looks like and what it actually means for frontier communities.
Okay. Yeah, and it circles back to your question too, Linda. Where does everybody in the state, us as a network, have a voice and a seat at the table? So in Montana, and I'll try to do this briefly. So they put in their plan what's called the Center of Excellence. And above that is going to be a legislative governor-appointed type board to oversee everything. So it's going to have some legislators on it. It's going to have some Department of Health and Human Resources people on it, some hospital facility CEOs, some community. When that first level came out, it didn't have enough of that rural frontier hospital provider organization representation. So the state has gone back to re-review that, and we should be getting that back out in a couple of weeks. So that's the top layer of that. And before I get to the COE, I'm going to go to the side, and there's what's called they developed an advisory committee to all this work within this. And it's what we call in our state all the alphabets. All the MHN, MHA, MMA, all the associations and all the organizations. So all of the alphabets sit over here and are meeting quarterly to kind of help inform all of this work under the normal structure, governance structure, and then into the COE. So there's kind of different layers and levels where people will have a voice and some input into this. So getting specifically into the Center of Excellence, there's 2 sides to that. There's the strategy and analytics side, and then there's the implementation side of the RHTP stuff. The strategy and analytics side is where they're coming in. Somebody's going to put that together as the prime vendor, kind of organize the structure and all that. But really the meat and potatoes of that is there's going to be somebody coming to our state and looking at all of our facilities to do an assessment of how they're doing things operationally, clinically, financially, and do that assessment, and then hand off recommendations to the implementation side of that equation. And so you take all this, which is self-limiting. That's about a 2-year project within our plan of the strategy and analytics piece. The implementation piece, of course, is covered throughout all 5. And that's where a lot of the different things are really happening in that. And that's where that term right sizing comes in our state. And that's got a lot of people, rightfully so, upset about what does that mean. We don't know what it means, but when they put that verbiage in a plan and they start talking about that, we don't want to hear that. I mean, come to my community and we're a small 6-bed critical access hospital, and they go, "We've done the analysis. Here's our recommendation. You're now an REH." Maybe we should be, but that's our decision to make, right?
Exactly.
And so that's really where people are getting upset and concerned about. Everybody assesses themselves. They're doing all these things to try to figure out how to do better efficiently and to provide the care. So to have somebody else come in and tell you what you should do or what you could be is really doesn't feel well, doesn't sit well. We're kind of stubborn people in Montana. If nobody knows that, I might represent a fair population in Montana.
I had no idea.
I know. So that's kind of how the structure goes of that whole COE. And then I just want to put a little network plug into that a little bit. Within all that work, because we're leaders across our state, just like you all are across your states, we're trying to figure out where we have a part in that, because we have all these relationships. We have products and services that could help do some of the work. So we're trying to figure out as a network, where do we sit? And there's all this chatter amongst all the alphabets and all the vendors and all the consultants about who's going to do this work. And when we think about it, and I know this is probably not popular stance, but when we start doing that work, MHN kind of becomes a vendor in a way. Because if we got products and services, education or insurance or whatever we're doing, we're going to have to get paid for the work that we do, right?
Yeah. Sure. Yeah.
Which then that just takes more levels away from what happens at the facility, community, patient level. So that's kind of how the COE is set up, a little unique. We'll see how it really functions in about 6 months. Those RFPs are out right now. The strategy and analytics one is due May 1. They'll decide by June-ish. And then the implementation one is out, and it'll be about a month later or so.
And Ish does reside over in the alphabet soup.
Yes. So did that answer your question?
It did.
That's
It was
kind of
very
how
helpful.
we're structured. I don't want to get too deep in the weeds of that, but that's the high level.
So the state of Illinois has those types of words in their application. And
Really?
the only thing that we've seen so far, I had asked about, what is this? And it's like, well, we're not quite sure yet, kind of that type of thing. So we've been very involved in the conversations on the 3 buckets of funding that we're named as a sub-awardee on. But the other things that are in there is just, it really has been cricket. So I really like that idea. And I will say this is a huge, value. If I had not been sitting here, if I had not been part of NCHN, it's like, I didn't know that word. That's great. Let's talk about that. Let me take an idea forward. So that's a great example of being able to share the collective knowledge and it may not work the same way, but at least it's, some consideration of we learned something and it sounds like it could be replicable, which is something that this program should be doing. And I know there's interest in trying to do that. So we've had a couple of conversations with our states on how do we take this package and, kind of put a bow on it and say, here's something that could be replicated. We have a great example of a program in one of our communities that is called Railer Reach, and it's text messages to high school students that are positive messages. And it was an attempt through their community health needs assessment to send encouragement to kids on a regular basis. Where do they look? They look on their phone. So kind of just the structure and the administrative portion of that and getting that up and running. It's not expensive, fairly straightforward, but you can't ask that hospital to put that in a package. And they've done programs and they've had conversations with other hospitals that like that idea, but trying to say there's programs that need to be kind of packaged with a bow and say, okay, you take this, but here's a policy, here's a procedure, here's kind of a structure, a governance if you have it. What if you have a committee? What's the committee charter? All those kinds of things, just to be able to replicate those ideas and scale it across communities in your own state, or if it's something that can be done as an idea across the country. I understand that's the idea at some point, is that CMS will have things kind of categorized or identified so that maybe I read that 3 years from now, but because I'm sitting next to her today, it's like, okay, we're going to start talking about that
And that's
later
today. That's called, what is it called? Railer Reach?
It's called Railer Reach.
Railer Reach.
This is in Lincoln, Illinois. So their high school mascot, they're the Railers. So yes, that's where it came
That's
from.
awesome.
Yeah.
I mean, talk about getting upstream, right? And I've always said that, value-based care, in my opinion, is planting the seed to a tree whose shade I'm never going to sit. So how do we make the system, the system better, right? For my kids and my grandkids. And, we've got to get upstream. And so talk about the impact and the social effects of what we're seeing in social media and the depression rates. And that's just, I love that idea. I think that's something that should be amplified nationally. And so I would love to pivot slightly to you too then. So ICAHN obviously has been long known as a leader in rural health collaboration. So kind of a two-part question. One, because you kind of dove in a little bit on that last piece. How does RHCP either accelerate or change your existing model? And I'd love for you to talk a little bit about those three pillars of workforce, disease, and tech, but specifically on workforce. I know you have a grow your own program that you guys are doing. So kind of a package in terms of existing, how does it accelerate or change? And then let's talk a little bit about what you're doing from a grow your own.
I think it definitely accelerates that collaboration opportunity. We have several examples of informal kind of collaborations in a region between 3 or 4 hospitals, and then having conversations with a CEO at one of those of how then they can scale what they're doing with some partners in a region to identify where where data is showing, or that one hospital has a program, or they begin to share provider so that there's more coverage over a broader area, which then makes it easier to recruit. You're not relying on an urban hospital to throw you the time that may be available, and always risk the situation where the specialist gets pulled back, and then you don't have that for your community anymore. So I do think it does accelerate it in those places, and also being able to also facilitate through some of our regular networking and engagement processes and opportunities that we already have within ICAHN to bring some of those success stories to different places. So that as there are successful ventures or things that have already taken place in the past, it just accelerates that those conversations of like, oh, what are you guys doing on this? What are you doing on that? And changing some of that, even from the standpoint of a meeting structure, that our members have indicated that they want to have in-person meetings more. And we know the value of sitting here having informal conversations. You can go to a conference for a day and learn some things and talk to somebody at lunch or a break, but having some of that other time to interact and really understand and ask some of the questions that we're evaluating how we communicate with our members. And in this case, moving into some in-person meetings. Just turning to the initiative on the workforce. So there are a number of hospitals in our state, and I'm sure in other states, where they have grow your own type of programs. If there's an employee that is interested in advancing their career, that's good for the hospital, of course, and it's good for the individual. Those individuals are likely to stay working at that hospital. They're committed to the community. So the structure of the money for workforce development, workforce, I don't know if it's necessarily development, but growing your workforce, is to have it come through ICAHN, and then our hospitals will make a request to ICAHN of, this is where we need nursing, or we need lab techs, or whatever that may be. But to fund those types of programs so that they can get more money in their hands, so to speak, to then pay for some of those educational programs that they may not have been able to, just for lack of funding, because they're dependent on how many people play in the golf outing that year, or the previous year. If they have a really good,
funny but facts.
So
really good year in their gift shop because somebody found something that was, a really, really great hit. So the bake sale wasn't, as successful. So, so having supplemental money to that, but then also saying to the state, there's another number of other factors like paying for childcare, paying gas cards, or even transportation to classes. If you have somebody that, some of the great stories are people that are in EVS and they say, I want to do something, but I'm limited on my hours because I have childcare issues, or I can't drive to the community college that may be 30 miles away. So taking into consideration some of those factors, because they're already working in your hospital, they want to do something, they're just not able. Hospital would love to do something for them, but putting in place some or growing on some of those programs that already exist to support the workforce that you already have and that already knows your hospital is always already committed to that community and wants to further their professional development to take their career to the next level within a hospital.
That's awesome.
Yeah, it's cool stuff.
It really is. Well, I and I don't want to steal NRHA's thunder because I don't know how much we can and can't talk about, but I'm really excited about some of the other initiatives that we have heard about, specifically as you talk about sharing providers and regional approach, and what are we going to see from an exemption from Stark and anti-kickback. I think there's some really exciting things. The takeaway I got was that we're not entirely sure what that acronym is going to be. There's one word in there that gives a little bit of a caution.
That word should not be spoken at this table.
So more to follow on that, but I do want to take it back to the national level. So we zoomed in. Now we're going to zoom back out. So Linda, from your perspective,
Okay.
how do members like these networks help ensure independent hospitals survive and thrive in the new era of what we're seeing from this transformation program?
Quick answer, and it's not a cop-out answer, keep doing what they're doing.
Yeah.
I mean, like I think Angelina said, and it applies to all of them, but Angelina made a comment, we've been doing the work. We're doing it. This money might help us, might expedite some things, but we're doing it. So that's my short answer. My little bit longer answer is continue doing it. And also, again, it may be different in every state, but make sure as best they can to be that voice at the table. And if they're not in the room, knock on the door of the room. And if the door knock's not being answered, knock harder, right? So make sure that they have that voice at the room. And also one of the things I've heard within some of our calls and our virtual meetings we have throughout the year, as well as the couple days of the conference, is our membership talking about doing things with each other. Like you were talking, Montana joins you in one of your alphabet soup programs. PBA. And I heard somebody talk with one of our members in Idaho having a mobile service and talking about, oh, I think it was you. I said, oh, Bobby, you need to come and park that mobile right here on the line and we'll do. And so I think, yes, community specific, community needs. What is this community? Because this community in Illinois is way different than this rural community in Illinois. So knowing that, yet at the same time, opening that vision to, oh, okay, Angelina and Zach are doing something Colorado-wide, but what could the four of these folks, and I'm just pointing them because they're the ones here today, what could the four of these folks do that raises that voice, expands their services? And so while we do need to think at the community level for certain things, I think we also need to look at state, regional, and national levels of how we hold together. So I think they have great voices in their communities and in their states. Some of them, these four in particular, as well as some others, have ears at the national level with FORHP, HRSA, NRHA. There's some really good relationships there. So there are some voices being heard that I think in some years past weren't being heard. And I think that needs to continue to grow. And I know it's a tiring and a daunting thing to do. But I think with the focus that's on rural now that I don't think has been in this way, they've done it. They're doing it. Keep doing it.
Yeah.
Yeah. And John, can I add a little color
Absolutely.
to that? So I think
I never get to say anything that he doesn't add color to.
War continues.
Thank you, Phil. I appreciate you.
We miss you, buddy.
Yeah. So I just want to say that, when you think of that national level, I think we got to think of NCHN, right? And Linda and the voice that she can raise for NCHN and all of us in the rural frontier stuff. I mean, we're kind of talking state specific, but the way I looked at that question was the way Linda's out there and she's meeting with all these people, growing new and different relationships with the people that you spoke to and about. So I think that's a huge piece of what we do. So we need to continue to grow this great momentum that we've gained within NCHN over the last several years and just keep on growing that, getting more people involved, more people engaged. So to our NCHN members out there, or people that want to join us, get on the calls, their monthly calls. You got different opportunities to learn and share, maybe from some of us on occasion, right? But I mean, that's the best stuff that happens right there.
Absolutely.
And when I talk specifically RHTP, I mean, we're all going to have our own little nuances and craziness, right, around the RHTP stuff. But we are actually going to start now an RHTP call on a monthly or bi-monthly basis. I don't know what the rhythm is. So
monthly.
We can keep on top of this because it's going to be ever changing. So I guess long story short, Linda, kudos for all that you do as NCHN. People get involved. And let's just keep doing the work.
I love it.
And dare I say that if the right people are at the table that have knocked on the door and are sitting there, then that disconnect in federal legislation or ideas that, telemedicine or, all the shiny new objects will work everywhere will be successful and changing that tide. And that's where I dare say the T word at this table that, that's where the transformation comes, is because like you referenced in the military, it's the people at the front line. We know it with patient care changes that you talk to the people in the front line. You don't design it in an office up in administration. You have to really know, what that process is. So there are examples of that. And now, like Ward said, there's a momentum there. We need to take that momentum from organizations like NCHN and pair that then with the heightened interest in rural at the federal level. And I think that's where the transformation can really come, regardless of what you do with $50 billion. But we need to get past the situations where we need to have money thrown to us on occasion. We need to reform the payment system. We need to have policymakers and legislators understand, the ramifications of those decisions. And we need more than hospital people saying that. We need the entire rural population saying we're not going to be second class in this situation, from our healthcare to our schools, school funding, or
Roads,
all the roads, all the other
internet.
things. So I think it really is the transformation of that needs to occur in the rural communities with that rising rural voice to say we deserve as much and as equal as a citizen as what somebody does that lives in
Dallas,
Chicago, Dallas, wherever. Yes.
Touche.
Well
Touche.
stated, Tracy.
Well, as they say, if you're not at the table, you're on the menu. And I think that
yeah.
these people and the rest of these networks need to see the table, because they're the ones that are doing the work and driving the change. We had so much other stuff that I wanted to cover, but I want to be very cognizant of our time. We could have talked technology and AI and value-based care and all of these things. We may have to get back together and continue the conversation.
To fly us all back.
That's right. Next
month, or
Well,
maybe
we'll
give us a
work.
break.
We'll
Give us
work
a
with
break.
Elia next year in Seattle. We'll set something up. So we'll keep the conversation going year over year. I think I like where this is headed. But I certainly want to end on a really high note. And so I'm going to ask each of you, and Linda, I'll probably start with you. We'll work back so I can close this out. What gives you optimism right now about the future of rural healthcare?
These folks and folks like them. I would not keep doing this job if I wasn't working with and for people that were so talented, so persistent, so dedicated, and just the work that they do and the passion that they have. And then that trickles down into their communities and ultimately to the patients. And so really that's what it's about. I get to work with awesome leaders, and that's what helps me to do what I do to support them, because then the trickle down effect is where we want to get to.
What gives me optimism? No, in truth, I think when HR 1 passed, I have a 11-year-old niece, and she asked me, Auntie Elia, what are you going to do? This is really bad. I do talk a lot of politics I educate her on why her vote will matter one day. And I said, I am just grateful that I am in this position I'm in. I've had 6 years of training, and collectively we have 250 years of executive rural experience. And that gives me hope. We got through COVID. It was hard. Never want to do that again. And I feel good about I feel good about the team.
I don't know if I have anything to add. You both said it so well. I think it's a privilege and an honor to work in rural healthcare. So that's my members, the staff that I work with, now our Eastern Plains partners, these partners fill my cup. So I feel pretty optimistic most days.
Yeah, me too. And I, again, echo all that they said. It's all about the people and the relationships, and all the good people that us, networks, the hospitals, right on down to all the people that work in this crazy industry we call healthcare. I think they give me optimism because they're quality, they're qualified, and they're going to keep in the fight.
I had an event on my calendar in late January for 2 days, 2 full days blocked out to go and participate in the medical student interviews for the University of Illinois rural medicine program. And the week was going on. It came Tuesday, Wednesday. I'm thinking, 2 days. Do I really want to do this? I hadn't done it before. Those were the best 2 days ever, because they were kids sitting at that table, and they were college kids, coming out of college. They were kids. They were from rural communities. They wanted to return to rural communities to practice medicine. And their personal statements, we had all their application materials to go to med school, but then had the opportunity for a group of, there were about 10 different, some providers, some people like myself, somebody from one of the rural hospitals, to come in and sit in front of a table of all these people and say, why do you want to convince us that you want to be in medical school? We're making a decision about your future. And the stories that came out of their mouths and the personal statements that they read about their rural upbringing and why they felt called to go to medical school, not just any medical school, but one that focused on rural practice because they wanted to return to their communities, was so inspiring and gave me so much hope that we've got people that are out there that I wouldn't necessarily interact with on a regular basis had it not been for that event. But those are the ones that say, yeah, I grew up with these people and I want to take care of Mr. Jones because he lived next door to me my entire life. Those stories. So that gives me incredible hope, in addition to all the people I work with, people on our team that are so dedicated, but also across the country and in the rural hospitals that, wear different hats and do what's right every single day.
Absolutely. And that's what I tell you, what gives me optimism right now is that this and the other members of NCHN and your member hospitals, that is servant leadership in action every single day. What gives me hope about the future and the optimism of the future is you talked about that you are already doing the work, Angelina. Another saying we had in the Army was, we have now done so much with so little for so long that we're capable of doing nearly anything with nothing. And that gives me optimism because the work continues and the people that are out there doing it won't give up the fight. And that is what really excites me, that the word I would use is grit. That grit is what's going to drive us through. It's the operations, it's the action, it's not the buzzwords and the transformation. It's the people doing the work every single day. So I truly appreciate you all joining us. I wish we had more time. We will certainly continue this conversation. For the audience, if you're a rural health member and you have a rural health network in your state and you're not a member, you need to reach out, because the networks are the multipliers. And I don't think this program works without these networks. If you're a network and you're not familiar with the National Cooperative of Health Networks, you need to reach out to Linda and have a conversation, because this is your peer group. This is where the stories and the collaboration start at a network level. So please reach out. Appreciate you all joining us today for Perspectives with Pinnacle.
Thank you so much, John.
Let's certainly keep care local and move healthcare forward together. Thanks so much, guys. Appreciate it.
Thank you.
Thank you.
Awesome.
Pinnacle is your partner in the business of healthcare. Nationally recognized for helping clients manage risk, improve performance, and drive innovation. For more information, visit our website, asksphc.com. For more information on our guests, or to learn more, please visit their websites.